Here's case 1 in your EMT course. There's some prerequisites, things that you need to already know, which you will have learned from study in lab as well as your independent study. And these prerequisites include how to find a location on a map using cross streets and using information that you know about where an odd or even numeric is on the east or west or north or south side of a street. It's important that you know where the location is, and so you can plan your approach. You want to plan your route. We'll talk about ways to plan that route as well as things that impact that in terms of time of day, traffic patterns, weather. We'll help you determine the appropriate use of lights and siren, how to communicate with the dispatch center, and how to drive safely and urgently to the scene. We don't have the ability to practice the actual driving as much as we would like at this point, but we can certainly go through the mental piece of that, and we emphasize that safe response. Also, we need you to review and be ready to perform assessments and vital signs checks, know some definitions, signs and symptoms, treatment of hypovolemic shock for this case. Some of the other cases will have additional or different types of shock. Need you to be familiar with the O2 therapy protocol and be able to use your reference card for that. And we need you to be able to safely lift and move and use the ambulance cart. And then how to communicate with those various reports that you're going to do. Your handoff to the ambulance crew if you're not transporting, your inbound report and handoff to the ER if you are transporting, and your written reports in every case. For this first case, there's some specific terminology. You should have looked these up and worked on memorization of these terms, and this is a good use of flashcards that you make. The terms that we're going to be involved with in this case are hematemesis, hemoptysis, hematochezia, coffee grounds emesis, dark tarry stools, what are esophageal varices, and then what do the terms hypovolemic, hypertension, hypotension, and tachycardia mean. We want you to use medical terminology in your communications. So for this first case, we're going to use the system information as below. The time and day is now, whatever time you're in class running this scenario, that's the time and day and date that we're going to use. And so that would indicate that this first case doesn't really matter what time of day or what season we're in. It is what it is. You have a 5-minute response time, relatively short, and you're going to wait an additional 5 minutes until the transporting ALS unit arrives behind you. So you have 5 minutes with your patient before the paramedic ambulance shows up. At that point, there'll be a destination decision that's made. You can go 12 minutes to a full-service ER or 3 more minutes past that to a trauma center. We won't always do it this way, but the first couple of cases, we make it pretty linear for you to where you can make your decision to go to the local hospital rather than the trauma center, and then you can amend that decision if needed because you're going in the same direction. And your role in this case is a first response BLS unit. You cannot transport. You're dispatched to a Delta response, which is predicted to be pretty high acuity, and it is for vomiting blood. The address is 1800 North Route Z in Columbia, which is a large warehouse facility, this distribution facility for American Outdoor Brands. The cross streets are Enterprise Drive and Karen Avenue. So given the cross streets and that even numbered address, you should be able to determine where that location will be. It's a Delta response, so we're going to use lights and siren. It's predicted to be potentially life-threatening. And your route would be pretty simple. I-70 to Route Z and then north a little bit, or you can run out east on St. Charles Road to Route Z. And so those of you that are not from our system, that's fine if that doesn't mean anything to you, but we need you to be able to use maps and plan routes. And this is a very straightforward route on this first case. What do you do during the response? Well, you drive safely, but you're also considering what's going on. And so vomiting blood, which would clearly indicate some internal bleeding of some kind. And when you have bleeding, you could have hypovolemic shock, so be sure you know the signs and symptoms and treatment, and you're kind of starting to make a plan on what your call is going to look like. Doesn't sound like it's trauma, but that doesn't mean there isn't an urgent need to replace that lost blood volume. And so while this may not go to the trauma center, it may be treated in terms of a trauma, in that there isn't much you can do at the scene for a trauma patient other than move them quickly to a place where they can get some blood replacement and get some sort of control of that internal bleeding. There's no obvious safety issues at this scene, and other than the body substances. Obviously, vomiting blood is a deal, but there's no people with guns, knives, and trying to harm you like there may be in future cases that we do. Here's the scene info. It's an extremely large warehouse distribution center. They do have on-site first responder security staff that are flagging you down toward the main entrance, which looks like where all the offices are. And the security first responder that lets you in tells you that your patient's vomiting blood and he's in the bathroom near the front door. You walk into that bathroom and there's another first responder in there who tells you that this patient has been vomiting blood for a while. He's flushed the toilet 3 times and it was pretty full of bright red blood. Of course, we don't know how much that really is, but it's a lot. So 3 toiletfuls of bright red blood should get your attention right away. The first responder is able to measure pulse oximetry. This is one of the rare cases where a bystander will be able to give you actual vital signs. And the pulse ox is reading 98%, and it's measuring the patient's heart rate at 130. And then the first responder tells you that the patient thinks he's about to pass out. Your initial contact, gentleman's leaned over the toilet, vomiting blood, propping himself up on the edge of the toilet. He's not actively vomiting as you walk in. You say, "How you doing?" He says, "Terrible. What's your name?" He gives you his name. "How old are you?" He gives you his age. So you now know that he's relatively oriented. You go to a radial pulse and you can't find one. You note that his skin is cool, pale, and moist. So right now, at this point, you're pretty sure this patient is in hypovolemic shock. While you're still holding his radial pulse, you note that his ventilations are a normal rate, non-labored, good depth, and he has no cyanosis. Plus, you've already got that pulse ox reading of 98%. So at this point, you can pretty well determine that this is a circulatory problem and ventilation oxygenation are still intact. Do you have urgent actions here? Well, if this was external bleeding, you would jump right on controlling that external bleeding, but this is internal uncontrollable bleeding, which means you need to prep him for immediate transport. You'll probably need to send somebody to help with the ambulance crew. And in these scenarios in our class, we're not going to have a fire department driver. We're going to make believe that the policy exists, that only ambulance crew drive ambulances, but that will mean they would need additional help in the back. So we'll need to send one or more folks from your team, the first responder team, with the ambulance. The patient is leaned over the toilet, thinks he's going to pass out, so let's prepare for that, protect him, hang on to him. Certainly don't need to add to his problems. And then we're going to treat for hypovolemic shock as best we can. Oxygen if it's available, and certainly you have some, and then with the appropriate means for that we can discuss. You want to keep him warm as best you can, although covering the man with a blanket while he's leaning over the toilet doesn't make a lot of sense. And we're going to prepare for rapid transport. You can't really control the internal bleeding, so the idea is to move him somewhere where the source of that bleeding can be identified and dealt with, and then the consequence of that bleeding can be treated by replacing blood volume. And while we would normally like to place our hypovolemic shock patient in a supine position, that would not make much sense in this case. The poor guy's vomiting blood. So you're going to move on to gather some data and info. If the ambulance is there, then let's get in the ambulance. If the ambulance is not there, then we're going to measure vital signs that we have already estimated. So he has no radial pulse. We know his blood pressure is poor, low. However, let's go ahead and try to measure that. And when you do measure it with some difficulty, you get 90/30. So we want coaches to remind you of which of those is systolic, which is diastolic, and talk about the term for the difference between those two, pulse pressure. And that's a pretty wide pulse pressure. We're going to measure his heart rate at 130, which the pulse ox already done, but you do it with yours, and your pulse ox reads 98%, and you actually count his breathing rate now at 20. So you've estimated vitals prior to this, and now you're measuring them in this step. The patient began vomiting bright red blood just before the time of the call. He was well prior to that, doing his normal work. He's an office worker at this warehouse facility. And we've got 3 or 4 toilet bowls full of blood, some spattered on the floor and the wall. And like I said before, we don't really know how many cc's of blood loss this is, but the point is, it's a lot. Past history and meds, really no meds, no allergies, ate breakfast a couple hours ago. He's had this before, and he has some esophageal issues. And so whether you actually know what esophageal polyps are, or you actually recall what esophageal varices are, it would be helpful if you did, but you can still treat this patient if you're a bit confused on what those exact conditions are. And the point is, you need to begin treatment even while you deal with the uncertainty of not knowing specifically what's going on. He had this before. The last time was about a year ago, and you're getting this information from a guy who feels terrible, who's leaned over the toilet and intermittently vomiting blood. At least at this point, we'll say that he's not actively vomiting, but he is still retching and is still very uncomfortable. He's fully oriented. You don't notice any odor of intoxicants, no indication of drug use. We always think about that, but in this case, it has nothing to do with the situation. As you do more of an exam, you find his lung sounds are clear, his belly's soft and non-tender, there's no injuries. And so at this point, you've pretty well decided that whatever's going on is probably related to his esophageal problems, and there isn't anything else complicating it. So you think, you act, and you recheck. And so you think about what's going on, you make a plan, and your plan is rapid transport, but you can't transport yet. So now you're pretty much just waiting for the ambulance to arrive. You've done everything you can to make that a rapid transition and a very short scene time for them. You're prepared to give them some assistance, personnel-wise, during transport, and then worked on logistics of how you're going to retrieve those personnel. And you get a couple more sets of vitals, and as you can see, they're trending in a bad direction. His pressure's going down, his heart rate's going up, his O2 saturation's dropping even with oxygen that you're giving him, and so this guy's getting sicker by the minute. Your next steps, let's decide on some oxygen. Probably seems reasonable for a cannula. I mean, he was at 98%, but and to put a non-rebreather mask on this guy would make very little sense. He's vomiting. And you need to prepare to catch that emesis and have your suction ready to go. Keep repeating vitals, and you're basically just waiting for the ambulance to arrive. When they do, here's your handoff to the ambulance, and you give his name, age, and be quick with this. And then what's going on is what they're wanting to know. So, hey, this is Doug. He's 35. He was okay until right before the call. Started vomiting some bright red blood. Now he's weak and dizzy. Thinks he's going to pass out. No radial pulse. Cool, pale, and clammy. So right there with just those couple of sentences, the paramedic ambulance crew knows exactly what's going on. And they have moved several steps through their assessment process to the critical decision point. They use the same process that you use. Then you can add in, he's got a history of esophageal varices, nothing else remarkable. Here's his current vitals. And that's probably happening while they're making contact with him and saying, Doug, let's go, and get him on the ambulance cart and get him moving. The inbound report that they will give will sound like what you would give if you were transporting. Start with the ETA, give a quick verbal picture of what's going on. The person on the other end of the phone or radio needs to be able to see what this patient looks like without pictures and video. And so he's 35, he's weak and dizzy, no radial, cool, pale, clammy skin, history of esophageal varices, pressure is this, heart rate is this, breathing this, O2 sat. And then when you say the O2 sat, you should also say whether or not he's on O2. And this is very quick, and I would suggest I could say this in about 15 seconds. And that's what they're looking for. They want to know, just what's coming to them so they can make a decision in the ER about what bed to put him in, how many nurses to assign to him, whether they need to go get the attending physician right now, and what else is going on. Your handoff to the ER is a little more personal, whereas in the inbound report you didn't tell his name, but now you're introducing him. And so, Doug, these are the ER nurses. They're going to take care of you. So I'm going to give him a little handoff. So this is Doug. He's 35. He was okay until right before the call. Started vomiting some bright red blood. He's weak and dizzy, no radial, cool, pale, and clammy. History of varices. His most recent vitals are right here. What you need to assume is that the person you talk to on the inbound report is not the person that you're giving the bedside handoff to. So just because you have talked to someone at that ER doesn't mean that all that information is passed along, and it's your job, and it's for patient safety, that you have a good bedside handoff. So then you go out and you start cleaning up your truck, you restock, you rehash, you get ready for the next call, and you think about what went well, what will I change for next time, gee, I wonder what this was, do I recall what varices are, do I need to look that up, maybe learn more about that, because now it's a pretty good learning moment for you. You've got a lot of visuals, a lot of cues that you can add to this that can make this a very vivid memory that you're able to store and then pull back up later as you start pattern matching with future calls. And then you consider also, so what if this wasn't just vomiting blood? How can I transfer learning? We'll talk about that in a second. Here's what your written report would look like. You can pause the video and read that in detail if you would like. Again, it is chronological. It has correct spelling and grammar. It describes what went on. It describes what we were called for, what we found, what we did, and how that turned out. And this is the written report that you would do as a first responder. Here's the one you would do as ambulance crew. Again, I'm not going to go through it word by word. I want you to pause the video and read through this. And I want you to write your own report without copying this, and then go back and compare. And then we want you to do what we call the video debrief, and that really should be in quotes up there, video debrief. And because there isn't really a video of this call, but there is one in your head. And so you want to look at that video and think about, how did I do? Was I professional? Was I organized? Was I confident? Even if I was scared and nervous, did I appear organized and confident? How did the team respond to me? Were there people freelancing and didn't know what I needed them to do? And then how did my communication go? Here's some questions you can ask yourself at the end of this case and discuss with coaches and peers. At what point did you know the patient was in hypovolemic shock, and why? Why did you decide that? But why didn't you put him supine? How should you position him? Because, our standard thing for hypovolemic shock is lay him down. Well, and that wouldn't have worked so well in this case. So did you really know what was going on? Could you remember esophageal varices? And even if you remembered what that was, are you absolutely sure that's what's going on? So this is where you start to deal with the field environment challenge of working with uncertainty, with incomplete information. And that's what makes field critical care medicine, which is what we do. That's what makes field critical care medicine so challenging and so potentially rewarding, is that you're working with incomplete information. You don't have full diagnostics. You're making judgment calls and a series of decisions. Then what if this was something else? What if it was hemoptysis? And then again, we talked about O2 therapy. Transfer this learning to other calls. So you just ran a call. Now, how can you use that to make you better at running several different types of calls? What if it was vag bleed? What if it was a rectal bleed? What if it was coffee grounds instead of bright red? What if it was dark tarry stools we were dealing with? What if he did have abdominal pain? What if he had abdominal pain but wasn't having any nausea or vomiting? How does this all fit in? So again, the idea is that you get the maximum amount of learning out of every case that you go on. And so this was case one for EMT.